Welcome to this last session before we actually then go into looking forward and having the open session discussion. So this is about sharing dementia care research, and actually we're now in that wonderful place of where we don't lack for data, but the question is, how do we use it, how do we organize it, and how do we share it? So we're going to start with Professor John Gallagher, who's going to talk about Dementia Platforms UK.
Thank you very much, Claire. In the Times Higher Education Supplement last week, Chris Arias of UCL gave a commentary on the risk of not sharing data. The risks of not sharing data are greater than the costs. He was obviously alluding to coronavirus and various other things, but it's equally true of dementia. This afternoon, I'm going to speak about one aspect of the Dementia Platform UK, rapid access to data. I'm not going to refer to recruiting to trials or resourcing multi-center studies. The DPUK data portal is a very sophisticated end-to-end data access management and analysis solution. It allows, we will ingest data as is, we'll take your data as is, and we will then curate it so that it's usable by third-party researchers. We are developing with Gates Ventures an interoperability layer so that we can access and make access to our data internationally across data portals. We have tools for discoverability, and then we broker access between the applicant and the data owner, because DPUK is exclusively a data processor, not a data controller under the terms of GDPR. We then provide everybody with their own individual analysis environment so that you don't download the data, you just access it online. And that allows us to have a fully secure and fully auditable solution. That is up and running. We are, hopefully in the next 6 months, going to develop what we would describe as a knowledge environment where we store code and data sets that are frequently accessed so that individuals can access them very easily, identify them and access them very easily for rapid replication, etc., etc. The challenge really is for dementia is what you might describe as multimodal analysis, and this actually is very, very complicated because if you're a specialist geneticist, you understand all the difference in ins and outs of SNPs. If you're a specialist imager, you understand all the different ins and outs of DICOM files and NIFTY files. If you are a specialist software engineer, you understand all the complications of a digital download. But if you're a multimodal analyst, which we want to encourage because we will have multimodal solutions for dementia, then frankly you need to process the data from these very high order raw data formats to what you might describe as standard formats, flat files. So what we do is we take the data in, raw uploaded, we change it using standard data models where we can. Where they don't exist, we make them up, so that you as the researcher can go into the analytic environment and you can look at genetic data, imaging data, digital data, survey data, all in your own environment and in a relatively accessible form. So how are we doing? So we have 42 collaborating cohorts. 38 of these accept our standard legal agreements. This is an important issue because what we're trying to do at every stage is standardize and streamline the procedures. Most data sets have grown up in a very bespoke fashion, and their solutions for organizing their data and for organizing access are perfectly good. However, they're all different. And if you are an analyst wanting to access 5 different data sets, to go through 5 different types of legal agreement, look at 5 different data models, before you actually get to look at something which is interesting, can be very, very frustrating. So 38 accept our standard legal agreements, 28 accept our streamlined access process, and 22 accept grouped data selection, i.e. they do not require you to pick individual variables. And when you're looking at the data sets of several thousand variables, picking individual variables is very, very time consuming. Over the 2 years we've been operating, we've had 160 project proposals. 40 of these failed what we would describe as triage because somebody writes in and said, give me your data. And we write back in a very nice way saying, no chance, all right? You have to make a case so that we know that these data are being used properly. And the case is made not to us, but actually to the data controllers, the PIs who manage and are ultimately responsible for these data. But this has involved 268 applicants from 72 institutions, 56 academic, 13 commercial and 3 government, over 16 countries. Involved 579, oh goodness me, it goes on and on and on and on. One of the important things is that the time required for a decision on an application is around 28 days. That's the median value. Of course, some people take an awful long time to make a decision on giving access, so the mean stretches up to 40. So, looking ahead, we have a very sophisticated data platform. It involves accessing data for about 3 million individuals over cohorts stretching from birth cohorts to more recently collected cohorts, some very, very detailed, looking at genetics, imaging, et cetera, some very, very, I think superficially is just the wrong term, but without such sophisticated data. And really what we want to do is to make these data accessible globally. So as I said earlier, we're working with Gates Ventures and the Alzheimer's Disease Data Initiative to develop a platform. We go to the US very shortly to report on our pilot study, and the expectation is that there will be a substantial investment, a global investment in this announced over the next 6 months. And we are building up relationships with other data platforms so that this is not just the Dementia Platform UK, which is promoting global data access, but actually it's data platforms in the States, in Canada, in Germany, in Holland. And hopefully, well, we're working on one with the University of Peking, but the decision has been delayed, as you can understand, for obvious reasons. And we're also trying to work up some enthusiasm in Australia for a similar concept. So, less is more.
Thank you very much. Thank you for a very tight presentation on an amazing initiative. So I'm now taking this and talking about sharing dementia care research data in care homes. And I'm using the example of a study that's just been funded. And listening to John, I'm thinking, my goodness, we're going to need to talk just to touch base on some of the things we're doing. So if I can just give you this statistic about residents with dementia in care homes, and this is from a paper published December, Raphael Wittenberg and people, some of whom are in the room, about projecting future numbers. And what they have identified is that by 2040, since 2015, there will have been an increase of 166% of people living with dementia in care homes. And by 2040, they are projecting that 49% of the whole population of people living with dementia will be in care homes. So that's an increase of 10% from now. So for those of us working in care home research, that poses particular issues and challenges. Adam kindly mentioned the optimal study. We tracked people in 12 care homes across 3 local economies to look at how health service research supported people with in care homes and with what outcomes. And our huge challenge was we didn't have a minimum data set. We had to generate our own data set to be able to follow people over those 12 months. And anybody who's doing work in care homes will always have that as their starting challenge. We also have recently just published a paper which has looked at all the intervention studies that were relevant to healthcare outcomes in care homes. This was commissioned by NHS England to explain why was it that some care homes were rapid adapters, could actually engage with the intervention and the innovation. And in that review and that consensus process, what we really found was that really there wasn't a systematic way of understanding the context of care. So that whilst everybody talked about, well, it's the culture, it's the leadership, it's the staffing, it's the size, these were all post hoc discussions. And actually what we were identifying is that you need to have these conversations way before you go into the care homes and have some comparative way of assessing the context and culture of these very heterogeneous providers of care. And then finally, really the issues around the limited opportunities to revisit the data, which I think is what this whole session is really about. And we do all the sexy topics, fecal incontinence and advanced dementia. But actually there was really impressive 10-year programs of intervention studies to try and reduce and manage incontinence in care homes for people. But really, they only got as far as saying that dementia is a risk factor. So we couldn't really say, well, what is it about how living with dementia affects your ability to engage with different interventions in different ways and with different staffing approaches and so on. So the DACCHA study has started in November, funded by HSDR. And really, this is about saying, okay, how can we establish the kind of data that needs to be in place to support research, service development, and uptake of innovation. So moving forward, if you like, what actually should we be asking anybody working in this sector to make sure they're asking and thinking about, but also to synthesize existing evidence and data sources with the data that care homes themselves generate and actually working to influence what that data should be from the care homes, which is a big ask, and there are a lot of corpses that precede this study that have tried to do this. So I'm not expecting you to look at it, but this is a 5-package study over 4 years, and I've really only got time to talk about 2 work packages. They're all standalone, but their findings all feed into each other. So one of the things we're doing, and so I was interested to hear what John was saying, is creating a care home clinical trial repository, because we recognize that for clinical trials, they all collect very similar information on resident characteristics and care home characteristics up to a point. So, for example, size, staffing, levels of funding, and so on. Outcome measures often overlap, and really capturing changes in residents over time. So trying to look at the care home resident. So what we will try and do with this is pool individual resident data to create a larger, more useful data set, which sort of is fairly self-explanatory, and to enable exploratory analysis to understand this population who we still don't really have a high level of granularity at because of the numbers that we can look at and how we can power it from individual trials, and reduce duplication, ask and refine questions without burdening staff and residents, because that is a massive issue for this sector, that researchers create a phenomenal amount of work, and even when we give them money, it doesn't always lead to them being able to work with us. We're working with the Virtual Trials Archive in Glasgow, who have a long track record of working on individual participant data repositories, which have looked at things like stroke and renal disease and so on. But we're not looking at treatment, and we're not looking at clinical conditions. We're looking at pooling all the resident data to be able to then ask the questions. We're not rerunning intervention studies. Now, as I said, we only started in November. This is work package 2, so we're really only at the stage of going back to those PIs of trials and saying, you remember you said you would be willing, but Lisa Irvin, who is leading this work, has pulled together this slide. And I think very quickly you can just sort of see that even with these trials, and there are people in the room who are the PIs on these trials, we've got over 4,000 residents that will be pooled, over 250 care homes. And looking at the dementia-specific issues, you can see where there is overlap, but also diversity in terms of which measures are being used and how outcomes are being used, and how that's being tracked in terms of resource use and so on. So now leaping over work package 3, which is a realist review, which we really haven't got time to talk about, but is the creation of resident data sets from routine NHS and local authority data. So I began by saying we have got a lot of data, and certainly we have a lot of data about care home residents in multiple places in NHS and local authority data, from GPs, from hospital, from ambulance and out-of-hours services, and also from adult social care. Integrated care systems are being rolled out across the country, and we're working with 2 who are particularly which are essentially local economies of care, who are working to use data collectively already. We're working with the Health Foundation. This is the first time that the Health Foundation is receiving money rather than giving money out, and it's created no end of trouble with their finance department, I have to say. But this is working with Adam Steventon and Arne Wolters from the Data Analytics Unit. And essentially building on their work that they did for the NHS Vanguards, where they have the permissions, where they have the secure platform of identifying and documenting sources of data on all care home residents. And the thing that they bring to this study is they actually can find care home residents. They can actually go beyond that problem of where postcodes don't actually quite deliver it without extra analysis. So what they will do is create 2 linked administrative data sets on care home residents, one for each integrated care system, so we can see how easy it is to see how all the different systems that the 2 integrated care systems are using, whether we can replicate it in both sides, but also what data can we confidently use that we do not require care homes to tell us about, which historically is what we have always tended to do. And then begin to demonstrate with them the benefit of routinely linking this data, giving them descriptive analysis, for example, of what is happening to certain residents in their care homes and in their use of resources and in their entry into care homes with the different partners and the care home managers involved. So DACSHA, I haven't got time to, the other work packages are about evidence review and surveys to guide healthcare implementation and assessment tools and core outcomes that are being generally used and provide a commentary on that. The repository I've touched on. Evidence, which is the realist review on actually how on earth do you implement a minimum data set into a care home situation that is already running with multiple strands of data collection, which is where MDS has always foundered in this country because we don't have a mandated system. And developing an implementation strategy that links existing routine data on care home residents with a modified and genuinely minimum data set with care homes, working to a prototype minimum data set. So that's what we're going to do. And the only reason we can do this, so you heard from Chris Kipps talking about applied research collaborations and their predecessors. And really, this is a team of 14 co-ops from universities, from social care, and from the ARCs. And that was how the questions have been generated. That's how the expertise has been tapped in. And this has actually genuinely got reach across the whole of the country. However, I have to say that everything you've just heard is only my opinion, not those of anybody else, and certainly not the Department of Health and Social Care. Thank you. So now I'd like to welcome Deborah Price.
Thanks very much, and thank you very much for inviting me here today. I'm at the University of Manchester. I'm a professor of social gerontology, so I come at this from 2 different sides, but today I'm representing the UK Data Service as one of the deputy directors, one of 3 deputy directors of that service. So for those of you who don't know much about the UK Data Service, it's a major infrastructure grant from UKRI via the ESRC, integrating economic and social data and providing that data to the user community. Just to give you some idea of scale, we have 23,000 registered users, 85% of whom are in the UK. We have about 90,000 downloads of datasets a year and respond to about 6,000 queries from the social and economic science user community. The UK Data Service has over 7,000 datasets, about 550 of which are open data, and about 6,500 are safeguarded data, and we also provide secure lab access in collaboration with data owners. So the general mission of the Data Service is to support innovative and policy-relevant research, support and improve data skills, and many of you will have come across the training arm of the Data Service as well. So how is that relevant for dementia research? We have a number of large-scale social science data sets for dementia, and in a moment I'll tell you why we think that's incredibly important. There are, of course, a number of people who undertake research into socioeconomic differences, social networks and so on. I'll come on to that. But just to give you an idea of our main studies that are relevant for dementia, we have substantial cross-sectional studies in the social attitude surveys, which measure public knowledge of dementia and also public attitudes towards dementia. And you can see those changing over time, over decades. We have a number of very important, globally important longitudinal studies. ELSA, the English Longitudinal Study of Aging, with about 9,000 participants, collects diagnosis, age at diagnosis. In each wave, there's a cognitive function module, and I'm going to tell you in a moment about the HCAP module, which was added to ELSA in wave 8, 2016 to 18. We also have one of the largest prospective cohort longitudinal studies in the world, Understanding Society, with 40,000 households participating. And in all waves, questions are asked about memory and ability to concentrate, learn, or understand. From wave 7 onwards, a question was added about how much difficulty people have with memory, and there's a comprehensive cognitive ability module that was undertaken in wave 3. We have also in the UK unique birth cohort studies, which contain an absolute wealth of cognitive measures collected throughout childhood and adult life that are just coming into their own as very, very important social science data sets. And these run from the 1946 National Survey of Health and Development right up to the Millennium Cohort Study, and then there's also the Avon Longitudinal Study of Parents and Children. So these follow individuals from birth to date, right through anything that happens to them until they die. But the UK Data Service also ingests qualitative studies with a view to not reinventing the wheel if the study's already been done. And the ESRC usually makes it a condition of funding that all interviews must be deposited with the data archive if that funding is granted. And so just to give you the sort of example, a few examples there of the kind of qualitative studies on dementia that have been ingested by the data service, including social processes of everyday decision making and so on. So if you are doing a study, it's worth checking whether your study's already been done and whether you could just access that data. So what is the advantage of using these large-scale general-purpose data sets to look at dementia and dementia risk? And I don't want to just talk about dementia and dementia risk, because you can also use all of these data sets to look at other things of interest to these communities and to dementia communities of research, including living with multiple conditions, frailty in inverted commas, because it's a contested term, but activities of daily living, instrumental activities of daily living, so excellent measures of disability, mental and physical health, and then well-being and quality of life. There are thousands of variables in these data sets followed over time, and they really are the only way that you can get nationally representative information about dementia and cognitive impairment, because you include undiagnosed people who are not formally diagnosed into a condition. And this gives more precise estimates and being used for these purposes of prevalence and incidence than can smaller scale studies or clinical studies. They collect a wealth of social, economic, biological and health data, allowing non-medicalized determinants of dementia and of well-being living with dementia to be determined, including socioeconomic status, social relationships, cultural engagement, loneliness, and social care, both formal and informal, because you're not only interacting with the formal systems in these surveys. The longitudinal designs allow patterns of change after diagnosis to be analyzed, and so, for example, you can estimate economic consequences of dementia, changes in social contact after dementia, and things that are very difficult to estimate with other data sets. And you can, if that's your interest, focus on well-being and quality of life, because these measures are very well validated. But the substantial data sets, and I'm going to come on to this in my last 2 minutes, give great possibilities for data linkage, because we have a enormous wealth of information about individuals. You can link technically to hospital episode statistics, to prescribing statistics, to GP records, screening data, dental data, and so on. You can link to national insurance records, you can link to mortality, and were data sets to come into being in a suitable form, we could imagine being able to link to social care, data as well. I wanted to mention the HCAP Worldwide, which is led by Andrew Steptoe, who I think isn't here today, unless he's in the room, at UCL, which is the harmonized cognitive assessment protocol that was added to ELSA in Wave 8. Thanks to the team at UCL for the slide. Just shows that this is a worldwide initiative with ELSA and a number of its sister studies. Sorry, can I take a minute? 1 minute? Yeah. Funded by the National Institute on Aging, and this is a substantial dementia protocol that's been introduced into all of these studies for those 2 years. So I'm running a minute slower than I expected. So I'm just going to say something about the Digital Economy Act in my last slide. It's a very important act for the sharing of data for research. But health and social care data is exempt from the Act. So these, I think, are the opportunities and challenges for the data service and for these data communities. The opportunity for interdisciplinary working across health and social science exists. Many questions can't be answered without social context, longitudinal analysis, and aging and dementia are just 2 examples of this. We have the data to answer critically important questions, and we have a strong aspiration to share data between health and social science to answer questions of global importance. But there are a number of challenges, the foremost one from our perspective being that health and social care data is exempt from the Digital Economy Act. There is a tightening environment for data security, which of course is probably part of the reason for that. There are issues of consent and linking without consent which play out differently in the 4 devolved nations where different legal advice is being given about research for scientific purposes. And if you speak to people who have undertaken these data linkages, they more or less wring their hands in despair. They're incredibly difficult, wading in treacle. They can take years. And the people who've bought into the data linkage may leave the organization and then the next person comes in and doesn't want the data linked at all. So very, very severe operational problems and issues between the devolved nations not speaking adequately to each other about sharing data. We have a vision. Thank you.
Thank you, and Seb Crouch, who rather wonderfully has told me I had no slides.
I've put my name on one slide just as a backdrop because I felt guilty. Not so. I was just asked by James to share a couple of very brief personal reflections of having shared data via the UK data service. And this relates to our Seeing What They See project funded by ESRC and NIHR about dementia-related visual impairment. And so this was, I guess, to John's point about multi-modality of data, this was a project involving everything from clinical semi-structured interview data right through to inertial measurement unit data about movement as people guided their way around a laboratory as we investigated the impact of things like lighting upon their ability to navigate a physical environment. And I suppose initially, so all the hard work was done by Kia Yong and the support from the service. If you've not uploaded data to one of these services before, fantastic training, really great support in answering questions about how to package up the data, and obviously an encouragement for everyone to write meta files about describing the kind of data so that before you even get to the point of registering or downloading data or accessing data, there's a really good understanding of what data might be available from each of the different projects. I suppose when James asked me to speak, I think he asked me because there weren't that many projects on, so I felt a little bit sort of like, oh, good, I've done my homework, I'm getting some sort of merit. Actually, I think secretly his ambition was to crush my will, because then when I went onto the service, I realized that despite all Kia's hard work, there was only one download of this particular set of data. And I think that perhaps speaks to a slightly more general point about our usage as a dementia care research community of services like this. I looked at some of the other projects. If you search the project title of the projects that specifically have dementia in the title, 3 was the highest download rate for any of the projects on there. And certainly when I looked around at some of the other data services, data repositories, the Bodleian Library, the social science repository run by Essex University, you type dementia into those repositories, you get 0 results. So I think it does raise the question of whether as a community we're aware enough of the services that are available and making use of the support and skills that there are available to share that kind of information. I guess my only other brief thoughts relate to things like the factors that facilitate the use and the reuse of data. There's a really useful OECD report out all about big data and sharing in the dementia field. And it highlights that it's not just sort of technical and consent issues, which people so often think about, but particularly by interviewing researchers thinking about some of the more personal factors which influence people's utilization of these sorts of skills, so particularly the skills they feel they have in uploading this kind of data and the incentives and the kind of mindsets that we have, that kind of inertial reluctance we have perhaps sometimes to share our data that might be helpful to other people. I think one other thing is thinking, and this is, I guess, a bit more confessional, is thinking about timing. I think often there's the perception that data sharing is something you just do at the end of the project. It's the sort of final act. It's often done at a point where the funding's actually finished. Some of the staff have moved on. And I think we perhaps need to be planning a bit like with statistical analysis. Statisticians tear their hair out if you come to them with a complete set of data and ask to analyse. Obviously, we all are in the groove of planning analysis from the outset of a project. And I think we really need to be thinking about how we plan not just to share our data and make it available, but how we promote and communicate to each other what we're collecting, and what will be available and what might be of use to other people in the same way that we do the results of our research. I think there are questions that have been raised by Martin and others throughout the day about the potential need for greater commonality of some of the measures that we use across our studies, which would help things like these repositories to link better across different studies. And I suppose my final point is my experience of the current round of ESRC and IHR Dementia Care Programme grants. It was fantastic that the ESRC have really brought the 4 different projects together. And right from the outset, there's great sharing of the protocols, the studies that we're planning to do. Lots of the grants have projects which link across the different broader programs. There's plans for how we're going to share this data, how we're going to publicise it at the events we hold together. And I hope that will hold us in good stead for the greater sharing of the data that we'll collect over the next 4 or 5 years. Anyway, those are a few brief thoughts. Thank you.
Right, well, thank you so much for that, those series of presentations. And we're now going to move to the questions for discussion at the tables. So we haven't got very long, but I think everybody is very practiced in answering these the 3 questions, and just some reflections and comments. Thank you.